All right, today we are diving into a really fascinating dilemma in medicine. It's one of those cases where simple high school chemistry clashes head-on with the messy reality of the human body. We're talking about a treatment that seems like a total no-brainer, but, well, as you're about to see, the evidence tells a very different story.
So let's start with a really simple question. Imagine you've got a patient and their blood is way too acidic. What's the fix? Think back to your basic chemistry class. What's the one thing you do to neutralize an acid?
Yep, you got it. You add a base. And in the world of medicine, the go-to base is sodium bicarb. For years and years, the logic was super straightforward. If there's too much acid in the blood, you just pump in some bicarb to balance things out. It feels so elegant, so simple. But, and this is the big question, is it actually the right thing to do?
Okay, section 1, the obvious fix. Let's talk about the problem of acidosis. To really get why this seemingly obvious fix is so darn controversial, we first need to understand what we're up against, and that's a condition called metabolic acidosis.
So, metabolic acidosis. This isn't just some abstract number on a lab test. It's a full-blown state of emergency for the body. When that pH level drops, it's like throwing a wrench into the works. The heart can't pump as strongly, the immune system gets all out of whack, and the body can even stop responding to life-saving drugs that support blood pressure. So yeah, the stakes are incredibly high.
All right, section 2, more harm than good. This is where we get to the hidden dangers of bicarbonate. And let me tell you, this is where our nice, simple story takes a huge plot twist. Giving someone bicarbonate isn't just a gentle nudge back to normal. Oh no. It can be like taking a physiological sledgehammer to the system, with some really serious and frankly weirdly counterintuitive side effects.
Okay, look at this list. The first one is just wild. You give a base to fix acid, right? Well, that chemical reaction creates carbon dioxide. And if your patient can't breathe well enough to get rid of that CO2, it actually builds up, seeps into the cells, and can make the inside of the cells even more acidic. How crazy is that? It's the complete opposite of what you're trying to do. And that's not all. You've also got the risk of fluid overload, messing with the calcium your heart needs to beat properly, and it can even make it harder for oxygen to get to your tissues. It's a whole cascade of potential problems.
Okay, section 3, intuition on trial. We're starting with case 1, lactic acidosis. So with all those potential dangers on the table, the evidence starts to paint a very different picture. It's time to put our gut feelings on trial. Let's start with one of the most common reasons for acidosis, a condition called lactic acidosis.
And boom, here's the verdict. The evidence is just crystal clear on this one. When you look at the major studies, they all say the same thing. For patients with lactic acidosis, giving bicarbonate doesn't help their blood pressure, and more importantly, it doesn't help them survive. The real solution isn't to chase a pH number. It's to fix what's causing the problem in the first place.
All right, let's keep this trial going. Case 2, cardiac arrest. You can't get much more high stakes than this. For decades, giving bicarb during a cardiac arrest was just standard procedure. Everyone thought you had to fix the acidosis to get the heart started again.
But guess what? The evidence just never backed it up. The American Heart Association saw this and pulled bicarbonate from their routine guidelines all the way back in 2010. And why? Well, study after study showed it didn't help, and some even suggested it could lead to worse outcomes, like lower survival and more brain damage. The focus shifted, rightly so, to the things that we know for a fact work. Really good CPR and shocking the heart as soon as possible.
Okay, on to our next case, diabetic ketoacidosis, or DKA. Now this is like the poster child for severe acidosis. If there's anywhere that bicarbonate should work, it's got to be here, right?
Nope, wrong again. When researchers pooled all the studies together, they found absolutely no difference in survival between DKA patients who got bicarb and those who didn't. And it gets worse. Not only did it not seem to help, for a certain group of patients, it turned out to be actively dangerous.
And this number right here, this is what's so terrifying. In kids with DKA, one big study found that giving them bicarbonate was linked to a more than 4 times higher risk of cerebral edema. That is life-threatening swelling of the brain. Think about that. You're taking on that kind of massive risk for absolutely zero proven benefit. It's a huge, huge reason to stay away from it.
Okay, one last case for our trial. Rhabdomyolysis. This is a nasty condition where muscles break down so fast they can wreck the kidneys. For a long time, the theory was, hey, if we make the urine less acidic with bicarbonate, maybe we can protect the kidneys from all that damage.
Sounds good in theory, right? But when they actually tested it, the idea just fell flat. Study after study, no real benefit. It turns out the thing that really matters isn't tinkering with the urine's pH, it's flooding the system with IV fluids to flush everything out. That's the real priority.
All right, Section 4, the rare exceptions. Now, I know what you're thinking after all that. Just get rid of bicarbonate, right? But hold on, that's not the takeaway. The lesson here isn't to ban it, but to be smart about it. It's about shifting from this broad, it just feels right approach to a super precise evidence-based one. So let's ask the question, when is it the right tool for the job? And this comparison really spells it out. Your standard run-of-the-mill cardiac arrest? The answer is no. But what if that cardiac arrest was caused by something very specific, like dangerously high potassium levels or an overdose on certain kinds of antidepressants? Then it's a completely different story. It's an absolute yes. In those very specific situations, bicarbonate isn't just a good idea, it's a life-saving treatment.
And it gets even more nuanced. Remember how we said it's a no for routine lactic acidosis? Well, a big study found that for a specific group of patients, those who had both lactic acidosis and kidney failure, bicarbonate might actually help them survive. And then there's a whole other category called non-antion gap metabolic acidosis. Now, without getting too technical, that's basically a type of acidosis where the body is literally losing its bicarbonate. So in that case, yeah, replacing what's lost makes perfect sense. So, Section 5, Precision over Intuition. Let's talk about the new rule book. When you put all of this together, what do you get? You get a massive shift in thinking. We're throwing out that old, simple rule of see acid, give base, and replacing it with a smarter, more detailed playbook that's all about specific situations and hard evidence.
And this table just lays it all out perfectly. Look at the pattern here. For almost everything, lactic acidosis, cardiac arrest, DKA, rhabdo, the default answer is no. Don't use it routinely. But every no has a really important but attached to it, a specific exception. The only clear yes is for NaHCO, where it just makes physiological sense. It really drives home the point. Precision is everything. So here's the bottom line. Sodium bicarbonate isn't just some harmless pH balancer. It's a serious drug with serious risks. And like any powerful tool, you don't just use it for everything. You save it for the exact moments when you know, based on solid evidence, that the good it can do is going to outweigh the bad.
And really, this whole story leaves us with a much bigger question, one that goes way beyond this one medication. The case of bicarbonate is a perfect example of that constant battle between what feels right and what the evidence proves is right. It really makes you wonder, in the complicated world of medicine, how can we ever be sure when our gut instinct is a brilliant guide and when it's a dangerous trap?